स्टार्ट करते हैं। डॉक्टर संदीप,
Yeah,
सर से
I
एक
will.
बार पूछ लेना, 8:45 सर रेडी है तो स्टार्ट कर देना। ठीक
Okay,
है।
okay, okay. I think Kosam sir has not joined it.
हाँ, ही विल ज्वाइन। मैं एक बार कॉल कर आएंगे बोले, अभी बात हुई, तब तक स्टार्ट कर सकते हैं, कोई दिक्कत
Okay. Should we begin then?
नहीं। 1 मिनट, 1 मिनट, 8:45।
हाँ.
मल्टीपल ऑप्शन स्टार्ट
इट्स 8:45।
So,
बाला सर।
Bala sir,
Yeah,
should we start?
I am ready.
ओके।
Okay, sir.
संदीप स्टार्ट।
So, yeah. Good evening, respected seniors and faculty members. Today we are restarting our PG clinics, and I welcome you all to this platform. Today's case will be presented by Dr. Umesh Vishwakarma. He is a second year DNB resident at JLNH Hospital and Research Center Bhilai. And our expert faculty for today are Dr. S. Balasubramanian sir. He is a senior consultant pediatrician at Kanchi Kamakoti Child Trust Hospital, Chennai. And our second expert faculty is Dr. Ajay Kosam sir. He is professor and head of Department of Pediatrics at Government Medical College, Rajnandgaon. So I welcome you, Dr. Balasubramanian sir and Dr. Kosam sir. Kosam sir is yet to join. He will join soon. And before going to case presentation, I would request our President Dr. Motwani sir to say few words.
Yeah. Good evening. Thank you, Dr. Sandeep. Welcome, Dr. Balasubramanian sir. It is nice to see you after a long break. We had PG clinics maybe last year. After that, there were some issues. So I'm happy that we are restarting it again. And Dr. Kosam sir is yet to join. All the respected seniors, my dear friends, and dear students. So I have just a small announcement to make. First of all, it is really pleasing now that we are able to restart this case presentation. And I thank and congratulate Dr. Umesh, who is is taking the first case today. Is presenting a case. And just one thing is, recently we had a Durg Bhilai Academy of Pediatrics EBM meeting. In that, the DBAP has decided that in this DBAP PG clinics, will select the top three students who have presented the case over this period of 1 year. So till next installation ceremony, how many, whatever cases, number of cases are there, and will give them a kind of incentive from the Durg Bhilai Academy of Pediatrics. So it was just decided recently, and I won't disclose here the who will be the jury and who will the this thing, but only thing is top three best cases they'll get incentive. The first prize will be 5,000 rupees, the second will be 3,000 rupees, and the third will be 2,000 rupees. So I know this cash incentive is nothing when compared to the amount, but it is a kind of token and appreciation for all those who are no presenting the cases and coming forward. So again, wish you all the best, everyone, and happy learning. Over to Dr. Sandeep.
Thank you, Dr. Motwani sir. And now I would request Dr. Umesh to begin his presentation. Umesh, you can start.
बोलिए ऑडियो जा रही है पेश कर
Please be loud.
गुड इवनिंग सर एंड मैम हेलो गुड इवनिंग
Yeah,
सर
yeah.
एंड मैम आ रहा है मेरा वीडियो
या
Umesh, you can
उमेश,
start.
यूर
You are
उमेश,
audible.
यू आर ऑडिबल। हम आपको सुन सकते हैं। प्लीज थोड़ा सा वॉल्यूम बढ़ाइए और प्लीज स्टार्ट प्रेजेंटेशन।
गुड इवनिंग सर एंड मैम रिस्पेक्ट Respected sir and ma'am, I am presenting a case of XYZ 2.5-year-old female child, resident of Kursi Park, Bhilai, who presented with the swelling over face and body since 10 days, brought to pediatric board of Sector 9 hospitals,
Please
admitted
move
with
your slide. Please move your slide. Yeah, now it's fine.
admitted with the complaints of puffiness of eyes and face since 8 to 10 days, swelling of bilateral lower limb and upper limb since 5 days, abdominal distension and genital swelling since 2 to 3 days, decreased urine output since 1 to 2 days, history of presenting illness. A 2.5-year-old female child, third by birth order, from non-consanguineous marriages, was brought with the complaint of puffiness around eyes and face since 8 to 10 days, insidious in onset, gradually progressive, initially involving periorbital region to whole face, more during morning hours, then decreases as the day progresses. This was followed by progressively increasing generalized edema, initially involving bilateral lower limb, starting from feet to knee, and later upper limbs, hand to elbow, and subsequently involving abdomen and genitalia. There is also associated decreased urine output with darkly concentrated urine since 1 to 2 days. Negative history. No history of breathlessness on exertion, chest pain, respiratory infection to rule out the cardiac causes. No history of anorexia, nausea, vomiting, jaundice, pain abdomen, blood in stool, blood in vomitus to rule out the hepatic causes of edema. No history of cola colored urine, headache, blurring of vision to rule out nephritic causes of edema. No history of fever, recurrent infections, weight loss, bony pain, blood transfusion, skin lesions, rashes, joint pain, drug intake to rule out the secondary causes of nephrotic syndrome. Past history. There is no history of TB, measles, no history of significant past respiratory infection or other past illnesses, no history of any drug intake. Antenatal history. Her mother was registered pregnancy, regular follow-up, and all 3 trimesters found to be uneventful. There is no history of torch infection during antenatal and perinatal periods. Perinatal and developmental history. Birth weight, the child having a birth weight of 2.5 kg, full term, normal vaginal delivery, cry immediately after birth, breastfeeding initiated with 13 minutes after delivery, no respiratory distress, jaundice, cyanosis, seizure, and no NICU admission at the time of birth. All developmental milestones achieved as per the age. There is a dietary history after calculation of 24-hour recall methods. There is a found to be adequate protein and nearly adequate calories. Immunization history. C has immunized up to age H per NIS. BCG scar were present. Family and socioeconomic history. The baby is living in extended family. There is no history of TB contacts, no history of similar illness in siblings or other family members. She is belonging to lower middle class of Kupuswami class 3 scale. Father is factory worker, mother is housewife, hygiene is poor. Summary. A 2.5-year-old girl child, third by birth order, born out of non-consanguineous marriage, full-term normal vaginal delivery, belonging to class 3 Kupuswami scale, and all developmental milestones achieved as per age, and fully immunized with adequate nutrition, was brought to pediatric ward with the complaint of puffiness around eyes and face since 8 to 10 days, and the swelling is progressively increasing, involving bilateral lower limb and upper limb since 5 days, abdominal distension and genital swelling since 2 to 3 days. With this, we would like to consider the child is suffering from edema of renal origin, most probably idiopathic nephrotic syndrome.
Okay, you stop here, Dr. Umesh.
Yes, sir.
And you please go back to very nice presentation. I must appreciate you. You are a final year resident or a second year resident or a first year resident in DNB or MD, Dr. Umesh?
Yes, sir. I'm just a second year resident at
MD or DNB?
DNB second year resident.
Excellent. Please go back to the first slide. Please go back to
Okay,
the
sir.
first.
Okay, sir.
Nice presentation. I must appreciate you. Good. Okay. Right. Now, yeah, next slide. Next slide. Okay. Yeah. Now, in the history, you have mentioned 4 complaints. Okay.
Yes, sir.
First is puffiness of face, then followed by swelling of lower limb, then abdominal distension and genital swelling. All okay. And you have also mentioned the duration. Okay. Please go to the next slide. In the history of present illness, always you must remember when you start your history of presenting illness, you must make it very clear to the person who is listening to your presentation about the timing of the disease process that you are talking about. For example, you have mentioned that the puffiness started around 8 to 10 days. Okay.
Yes,
Instead
sir.
of simply saying that the puffiness started, it would be appropriate and prudent on your part to mention how the child was 10 days back. Let me ask you, Dr. Umesh, was this child completely normal 10 days back or was not normal 10 days back?
Yes, sir. She was apparently all right at 10 days back.
Yeah. So, always start the history of present illness in such a way that the examiner understands when the disease process started. Okay. In fact,
Yes, sir.
a full sentence saying that this 2.5-year-old female child who was apparently healthy about 10 days back started gradually developing. I mean, did they not insidious? Yeah, you put it insidious. And progressive swelling of the eyes and face. That would have been better because that will make it clear to the examiner that the illness started only 10 days
10
back.
days back.
It's my comment number 1.
Okay,
Second,
sir.
you have made it very clear that the swelling went on to involve the lower limbs, then the upper limbs. Now it is involved the abdomen and even the external genitalia. Agreed. And you have also mentioned that the urine output had become less only during the last 2 days. I am surprised. With the baby who is developing such anasarca, I am sure the oliguria must have been there earlier. So, how did you come to a conclusion that there is decreased urine output? What question did you ask?
Sir, initially I asked to her mother,
How did you come to
how
a
many
conclusion
times.
that wait, let me. How did you come to a conclusion that there is decreased output only for the last 2 days and not before? What questions did you ask the mother?
So I asked her mother how many times she has passed urine.
Okay.
So she tell initially she was passing 3, 4, 5 times a day, and since 2 days, 1 or 2 days, she's passing only once or twice.
Do you think 4 to 5 times a day in a 2.5-year-old child is normal? That too, the summer has not started. It's still late winter, I'm sure, there in Bhilai. I don't know. What is the nighttime temperature there in Bhilai these days?
So 15, 20.
15, 20. Yeah, 15. Unlike Chennai, where it is 28, 29, even in March. In Bhilai, I'm 15, 20. Do you think a normal 2.5-year-old child will pass urine only 5 times a day or more? Usually more. In a
Okay.
2.5-year-old child, you would expect the child to pass urine at least 10 times a day, in late winter or early summer.
Okay,
So, sure, this oliguria started earlier than that. That is my comment number 2. What is you have said dark yellow urine. What is the implication of dark yellow urine? I'm going to ask you a different question. What are the various colors of urine which could give you diagnosis, or which will give you clues to diagnosis?
So, sir, if C is not passing urine or maybe oliguria, then
No. I'm asking a different question. What is the implication of yellow urine, and what are the various colors in the urine which could have diagnostic significance to a clinician? Don't tell me this is not related to this case. Everything is related. Anybody can put in the chat box. Other students can also put in the chat box and try to answer.
so maybe due to dehydration.
Do you get yellow urine when there is dehydration? See,
So
actually,
concentrated urine we can find.
concentrated urine. Concentrated urine will not appear yellow. It will be amber colored.
Okay, sir.
That is a description. The color of the concentrated urine when there is oliguria, when tubular function is okay, when glomerular function is impaired, you will always get a concentrated urine which will be amber colored. Okay.
Okay, sir. Yes,
On the
sir.
other hand, where will you get yellow urine? Where will you get which condition is yellow urine?
हेपेटिक ऑब्स्ट्रक्ट मतलब हेपेटिक कॉज होंगे तो
Hepat, only when there is bilirubin. Okay.
yes,
Bilirubinuria, you will get yellow urine, not when it is concentrated urine. That's my comment number 2. In addition, what other colors? Suppose the urine is black, what does it mean?
so
Urine
maybe
is black.
so if it is dark colored urine or cola colored तो
Black color, black urine.
so alkaptonuria मतलब
Pardon?
alkaptonuria maybe
Alkaptonuria, you don't get black urine.
on oxidized sample.
Green urine. You get black urine when there is intravascular hemolysis, black water fever, malaria, severe malaria, or hemoglobinuria, right? You will get a black urine. Then, have you heard of beeturia?
Yeah.
What is beeturia? What's the significance of beeturia?
So beetroot.
Pathological, physiological?
So beeturia usually मतलब physiological मतलब after having beetroots तो
Actually, if you read literature, beeturia occurs more often in children with iron deficiency anemia than normal children.
CPS 2763 है ना, मैंने उनको
Normal.
अनम्यूट कर दिया से ऊपर स्क्रीन में आपके नाम के नीचे ही है सर. ठीक है, तो सर को मैं बोलता हूँ कि कैमरा भी ऑन कर लो, बोल देता हूँ. ठीक है, नहीं, तो बस बीच में सर अपना क्वेश्चन पूछ लेंगे, है ना.
Beeturia, if it occurs, you should always think of iron deficiency anemia. When there are lots of oxalates in the urine, it may stain the diaper pink. Okay. You
yes,
can get white urine. Okay. White when there is crystalluria or when the urine is very concentrated. Right?
yes, sir.
These are all some of the colors. For example, you give anti-tuberculosis treatment, the urine may be orange colored. Right?
Yes,
So
sir.
these are all some clues to disease when you look at the color and try to identify the diagnosis. Okay. Dark yellow urine indicates bilirubinuria. You should have mentioned it is amber colored and is likely to be concentrated urine. That tells you it's not a tubular problem. It looks like a glomerular problem with decreased urine output. Okay. That
Yes,
is
sir.
the second comment. Please go to the next slide. Now, you have talked about, you have immediately gone into the negative history. Please go to the next, previous slide. Now, is there, other than these three symptoms of facial puffiness, then limb edema, then abdominal genital edema, and decreased urine output, nothing else is happening, isn't it? 4 symptoms you have mentioned. Am I right?
Yes, sir.
Okay. Now, coming to the negative history, please go to the next slide. What is the age of this child?
So 2.5-year-old girl.
How often, how many cases of chest pain have you seen in a 2.5-year-old child? And I can ask all the PGs who are listening also. How often have you seen chest pain in a 2.5-year-old? And why did you ask that? What's the significance of chest pain in a baby who has got anasarca? Since you have put only, I'm asking. So all negative history, you should be able to defend yourself as to why you ask. Why did you ask for chest pain? Dr. Umesh?
So to rule out the cause of cardiac causes of edema.
Cardiac. Which condition will produce chest pain and anasarca in a 2.5-year-old child? Give me some examples. How many cases you have seen? But don't talk about chest pain. 2.5-year-old is an absolutely, I would say, unrelated symptom.
Okay.
Why did you ask for breathlessness and exertion?
So if there is a complication होगा तो सर जैसे pulmonary embolism.
Pulmonary edema. Okay. Cardiac failure. Agreed. Recurrent respiratory infection. Why did you ask?
Sir, if there is a
You have said child was well 10 days back.
yes, sir.
Question, what's the significance? Suppose there is history of recurrent respiratory infection, the same story of 10 days of anasarca. What does it mean to you? What disease did you think of? Others can put in the chat box. Other PGs can also interact. Dr. Motwani, you can encourage other PGs also to take part in some way. Poor Umesh alone should not be targeted.
So,
What's the significance of recurrent? Why did you ask recurrent respiratory infection? That's my question to you. Okay, let me make it very clear. I think it is totally irrelevant. Totally irrelevant. You have said previously normal child who developed edema like this. I don't think it is significant at all. Significant. Okay. Anorexia. Why did you ask anorexia, nausea, vomiting, jaundice, pain abdomen, blood in the stool, blood in the vomiters? What all did you think of? What other conditions did you think of?
if you want to rule out the hepatic causes, if hepatic involvement is there.
Hepatic. See, hepatic causes, see, the parents would have noticed if the urine is yellow, the eyes would have become ectric. Okay.
Yes,
Right?
sir.
Okay, still, okay, I grant you it's okay. What about cola colored urine? We already discussed. Headache and blurring of vision in 2.5-year-old child for hypertension, is it?
Sir,
Is it for hypertensive encephalopathy?
no, sir. If
Then what?
just
Headache
to
of
if
vision for what?
if there is a component of nephritic, then hematuria or
How will nephritis cause blurring of vision and headache?
so hypertension, then it causes
Hypertension.
headache and blurring of vision.
Okay. No history of fever. Recurrent infections. I don't know why you asked. Why did you ask for recurrent infection? You didn't tell me even now. You have put it in 2 places. Recurrent respiratory infection, recurrent infection.
So if there is any complications matlab, pneumonia.
The history is only 10 days old. 10 days. Nothing has happened to the child other than edema. I don't think it is relevant.
Okay,
Weight
sir.
loss. You expect a child who develops anasarca to have weight loss or weight gain?
So weight gain.
Weight gain. Why did you ask for bony pain?
So malignancy or tuberculosis के लिए.
Malignant. Oh God. Malignancy 10 days. Absolutely normal child. Which malignancy will present like this with anasarca? Where? Which malignancy? Where? I don't think it is relevant. Blood transfusion, 10 days history, irrelevant. Skin lesion, of course, it is relevant. Why did you ask?
So secondary causes like SLE or HSP.
Oh, 2.5-year-old child, SLE. How many cases you have seen? Anybody? What is the relevance of skin lesions in this child? The only relevance is post-streptococcal acute glomerulonephritis following scabies and impetigo. You can defend yourself. That's the only way you can defend yourself. Right?
Yes.
Yeah. Rashes. Why did you ask for?
So
Significant
same.
rashes in a child who's got anasarca. Why did you ask and what condition did you think of?
So same streptococcal infection.
Streptococcal. No. Okay, rashes. Okay, skin lesion and rashes are same. The only condition I can think of, if I were you, I will defend myself saying that if there is a palpable purpura, one should start thinking of anoxcondyline purpura with renal involvement. You can defend yourself. Okay. Again,
Yes.
joint pain also same way, HSP. Drug,
HSP.
of course, agreed. Any non-steroidal anti-inflammatory drugs can always cause nephritis and renal failure and fluid and water retention. Okay. Next slide.
Yes.
Just 1 second, Umesh. I
Yes.
request all the PGs to please be active and you can interact. Also switch on the videos. And I also welcome Kosam sir. Kosam sir has joined, sir. Okay, please continue.
Yeah, Dr. Kosam sir, if you want to ask questions further, please start, sir. I will join. No problem, Doctor. Welcome. You are a very experienced person. You will definitely add value. Please go ahead, Dr. Kosam.
There was some problem with my mobile, so I joined from another mobile. Yeah, I wanted to ask the student that you have mentioned about cardiac symptoms, breathlessness on exertion, and etc. etc. And sir has already mentioned that there is no relevance of such symptoms. But there was one point where you mentioned chest pain, and sir had asked some questions. I wanted to ask one question that if there is a chest pain suggestive of angina in an infant, what is the possible reason of angina in a 2-year-old child?
So if there is a complication of nephrotic like pulmonary thromboembolism, then baby can present with shortness of breath and chest pain.
I'm asking about angina. Anginal pain in 2-year-old child. Can it happen?
Let me help you, Umesh.
Yes.
How
Sir.
common or uncommon is anginal chest pain in pediatrics? And if you happen to get a child who has typical angina, say retrosternal pain coming after activity, pain stopping the activity, okay? What are the conditions you will think of when a child classically presents with angina? In fact, recently I came across a beautiful article in JAMA Pediatrics. Maybe I will share during the next class. Beautiful case, a beautiful approach to chest pain in children. Very small, nice article. And of course, for sake of time, I will help you. Anginal chest pain is basically uncommon in pediatrics. And if you happen to get anginal chest pain, the following are the conditions that you think of. That is number one. Second point, other than thinking of the cardiac conditions, the first rule of thumb in pediatrics is that non-cardiac causes of pain, chest pain, are more common than cardiac. For example, if you are going to see 100 cases of chest pain in pediatrics, 95 to 99 will be only non-cardiac. Only 1 to 2% will be cardiac. But that 1 to 2% you can't afford to miss. That's what Dr. Kosam wanted to convey to you. Anginal chest pain can occur under the following conditions. If you ask me, in India, the commonest cause of anginal chest pain is severe anemia. severe anemia in your area, you are sickle, severe anemia, they can die suddenly because of cardiac standstill, secondary to 3 grams, 4 grams hemoglobin. That is one. Second, cardiac chest pain, anginal pain can occur in any severe aortic stenosis. The reason why you should remember is that moderate to severe aortic stenosis, you must prohibit the child from competitive exercise, which can kill. 3, any pulmonary stenosis which is severe, starting from valvular pulmonary stenosis to tetralogy of Fallot, you can have anginal chest pain. Severe pulmonary hypertension, severe Eisenmenger syndrome, long QT syndrome, Alcapa, okay, or other conditions where you can coarctation of aorta, or other conditions where you can get anginal chest pain. The last but not the least, children who have arrhythmias, children who have atrial flutter, atrial fibrillation, congenital heart blocks, long QT syndrome, so many other syndromes are there. I don't remember the names. Many syndromes which can cause all these rhythm abnormalities. They can all cause anginal chest pain, right? And it's pretty uncommon in a 2.5-year-old child. Dr. Kosam, you want to add anything?
No, sir, I think we have done every justice to the question and answered all of them. Yeah.
Okay. Please go ahead. Right. Please go ahead.
Yes, sir.
Yeah, go ahead. In the past history, why did you ask for history of TB and measles? Specifically, you asked for measles. Why? What has measles got to do with somebody who has what looks like a nephrotic syndrome?
So,
What's the
viral
significance of measles in this case?
infections precipitate मतलब,
Paradoxically, interestingly, in fact, it is the other way. There are children who have nephrotic syndrome who, when they develop measles, they will go into natural remission spontaneously. Go and read old books. I remember old edition, 9th edition of Nelson mentioning that nephrotic syndrome can go into spontaneous remission if there is measles. The reason being, measles is one viral infection which suppresses T cell immunity very severely. When there is T cell immunosuppression, it is almost like giving steroid therapy. They can go into remission. Measles does not precipitate nephrotic syndrome. It rather may cause remission of nephrotic syndrome. Okay? And TB, why did you ask?
so if there is, as in nephrotics, मतलब, nephrotic syndrome
If you
would be.
start steroid therapy, you must know whether there is any history of contact, TB, etc. Okay, history of significant past illness. What significant past illness did you ask in this child?
Sir, viral URI, maybe.
Yeah, many nephrotic syndrome relapse or can be precipitated by viral infections. Agreed. Drug intake. What drug intake did you keep in mind?
NSAIDs or
NSAIDs.
drug
Okay.
Penicillin, antibiotics.
Okay. Right. Go to the next slide. Antenatal. Okay. Next. Go ahead. Birth. This was low birth weight. What is the low? Wait. Low birth weight and nephrotic syndrome. What is the connection? Is there any connection? Low birth weight. Anybody can answer in the chat box. Low birth. Yeah. Somebody has put for anginal chest pain Kawasaki. Dr. Kaushik, you must be complimented. I forgot to mention. Kawasaki, of course, very important. I'm glad that he pointed out. Sometimes students, smart. Very good. Kaushik has mentioned that Kawasaki is an important cause for anginal chest pain. I forgot to mention. Sorry. Okay. Right. Then birth weight of 2.5 kg and nephrotic syndrome. Any relationship? Anybody can put in the chat box?
Sir, IUGR, जो low birth weight maybe IUGR, so there is a improper or impairment in the synthesis of renal system. So it will.
No. Anybody? Okay, let me put it, give the correct answer. Congenital nephrotic syndrome can be due to HIV or due to CMV infection. Both can produce birth of low birth weight babies, IUGR. That's the way you can defend yourself. HIV can cause congenital nephrotic syndrome. Congenital CMV can cause nephrotic syndrome. Okay, go
Yes,
ahead. Okay, diet history. Here, your diet history is giving only the present dietary history. You should have mentioned about, breastfeeding, introduction of complementary feeds, etc., etc. And of course, the rest of the things are okay. And you should also mention something about micronutrients because you don't know. I mean, rarely you can have severe anemia with anasarca. Okay, so
yes.
that's the only omission. Otherwise, it is okay. Please go to the next slide. Immunization. Okay, fair enough. Okay, next. Family history. Of course, you should have mentioned that whether there is any history of renal disease in the family. I think that would be appropriate. Please go to the next slide. Yeah, coming to the summary. Yeah, okay. I think this is straightforward. I don't think there is any other differential diagnosis other than a first episode of. In fact, if I were you, I would have mentioned that this is probably the first episode of nephrotic syndrome. I wouldn't add the word idiopathic. Nephrotic syndrome. The most common cause being idiopathic nephrotic syndrome. That's the way you would have summarized. Yes, Dr. Kosam, you want to add anything? You want to question? Please go ahead, sir.
Okay, this is a 2.5-year-old child, and you have mentioned that he is fully immunized. So, what is the significance of immunization in a patient of nephrotic syndrome? And suppose the nephrotic syndrome patient is started already on steroids, and the patient is planned for some immunization. So, how will you plan that?
So voice is not clear.
I wanted to ask that what is the significance of immunization history in a patient of nephrotic syndrome, and if you have already started corticosteroids in a patient of nephrotic syndrome, how will you plan immunization that is being recently scheduled?
So live vaccines should be avoided, and
Avoided.
and
Okay.
killed vaccine can be given like to prevent pneumococcal infections. So pneumococcal vaccine, varicella, influenza vaccine can be given.
And that depends on the dose of steroid and the duration of steroid, no?
Yes.
So when you are planning immunization, that depends upon the dose which you are giving and the duration which the patient has received that particular dose of steroid.
Okay, sir.
So what is that? How it depends? Anybody from the PG? If patient is already on corticosteroids, how are you going to plan or reschedule the immunization? Okay, so let me give you the answer. Suppose the patient has taken a high dose. High dose means 2 milligram per kg per day for less than 2 weeks. Then in that scenario, you can give the vaccine as soon as you have stopped the corticosteroids. Okay. But if you are giving high doses for more than 2 weeks, then you can give vaccination 1 month after stopping the corticosteroids. But if you are giving low doses, that is less than 2 milligram per kg per day, then we should preferably avoid live vaccines and field vaccines can be given. And if the patient's on alternate day steroid, you can again avoid live vaccine. Other vaccines can be given. So you have to plan the immunization depending upon the dose and the duration of the corticosteroid
Yes.
therapy. Okay.
Yes, sir.
Yeah.
Okay. Dr. Motwani, you want to ask any questions? The history before we proceed to the physical
No, sir.
exam.
I just had one small doubt. Kosam sir just said that alternate day steroids, if the child is on, you should avoid live vaccines. But
Yeah.
I think if I remember, only the child who is getting 2 mg per kg per day for more than 2 weeks, the child is fully immunocompromised, immunosuppressed, then you should avoid live vaccines. And I think alternate day steroids is not a contraindication for live vaccines, if I remember. Bala sir?
Agreed.
Basically,
Agreed.
it says that if it is a pressing need only, then only you should give the vaccine. Otherwise, you can avoid. Yeah.
No.
Okay.
Alternate steroids, you can consider giving live vaccine. Okay. No problem.
Okay.
Go ahead. Anything else, Dr. Motwani, you want to add?
That's all, sir. Please go
Okay.
ahead.
Dr. Umesh, you start presenting the case. Physical findings.
On general examination, child was conscious, alert, playful. Generalized edema was present, involving facial puffiness, abdominal distension, genital edema, bilateral pedal edema. On taking vitals, temperature.
1 minute. Please go to the page. See, always you postgraduates must develop the habit of describing the first impressions when you look at the child. Okay, pediatrician must give a look at the child, spend some 30 seconds looking at the child, head to foot, and then only should go in for the description of the child. Oh God.
Okay, sir.
So, okay, then only you should go for the description of the child. Always first thing is describing the child. Am I audible?
Yeah.
Hello?
Yes, sir.
Yeah, suddenly my video screen is gone. I don't know why. Oh, just a minute. Yeah. See, always the first impression when you see the child and give a cursory look, you should make it very clear to the exam. For example, the most important questions you should ask when you look at a child in general examination is, first is the child well nourished, obese, malnourished, or fairly nourished? 1. 2. Is the child ill or well? And if it is ill, whether it is acutely ill looking or chronically ill looking? 3. Whether there are any alerting or any red flag signs which are obvious. For example, a baby throwing a seizure, a baby having grunting, a baby having tachypnea. I don't think you should describe it after general examination. You should mention. You should say whether the child is well nourished, obese, edematous, having anasarca. That you should straight away start with the first sentence, and also mention whether the child is ill looking or well looking, acutely ill looking or chronically ill looking, conscious, alert, cooperative for examination, irritable. These things should come in the first sentence before you talk about edema and other things. Please make it a habit, Dr. Umesh. Is that
Sure,
clear
sir.
to you?
Yes, sir.
Okay, go ahead.
So on vital examination, all vitals was found to be normal or within normal range. Temperature is 98.6 degree Fahrenheit, measured in right axilla. Pulse rate 108 per minute. Good volume, regular in rhythm, no radiofemoral delay. Respiratory rate 30 per minute. And breathing pattern is thoraco-abdominal. BP is 102 per 60 mmHg, which is belonging to 50 to 90th percentile, taking in a right upper limb. SpO2 is 96%, and vitals were stable. And on anthropometry, the weight for age is 14 kg, height for age 92 centimeter, which are also considered appropriate for the age, according to the IAP growth charts.
Hmm. Go ahead. What about head circumference? Did you take the head circumference?
Yes.
What is the significance of head circumference in nephrotic syndrome in a 2.5-year-old child?
So there are certain syndromes which are associated with the nephrotic syndrome, then can be like microcephaly, as in case of Galway-Mobart syndrome,
Most
Pearson syndrome.
importantly, congenital CMV infection. That's the first thing I'll think of if there is microcephaly.
Oh,
The child with nephrotic syndrome, other than HIV. Okay, go ahead. Right.
on
So
head to
were
tail.
you able to palpate the femoral pulse in a patient with gross ascites and generalized edema? You mentioned radiofemoral delay. I don't think it is possible to palpate the femoral pulse in a patient with gross ascites. Palpate हो गया था? Quite difficult, I think.
Yes.
Okay.
Yeah. Next.
On head to toe examination, head appears normal in size and shape. Hairs were normal in color and texture. Face periorbital puffiness, facial puffiness were observed. Oral cavity, no ulcers, no fissures at the angle of mouth and lips. On eyes, no pallor, no icterus, and no other eye abnormality. Ears, no discharge. Nasal cavity were found to be normal. Neck, there is no rash around the neck. Chest is normal. Umbilicus is central, is stretched. Abdomen is tense and distended. Genital swellings present. On spine, there is no deformity over the spine. Extremities, bilateral lower limbs and upper limb edema present. Skin shiny over the edematous region. Skeletal system, there is no deformity.
Hmm. Go ahead.
On systemic examination, GIT examination, the child is examined in supine position. On inspection, the abdomen is distended uniformly. Flanks are full. Umbilicus is central, stretched. Superficial veins are prominent. No visible peristalsis and pulsation seen. No scars. External genitalia swelling present. On palpation, there is no local rise of temperature and tenderness. Pitting edema is present. On deep palpation, liver, spleen, kidney is not appreciable. Abdominal girth is 52 centimeter at the umbilicus area. On percussion, there is a shifting dullness present. On auscultation, normal bobble sounds heard. On respiratory examination, the normal vesicular sounds present and bilateral air entry equal. On cardiovascular examination, S1, S2 present. No additional heart sound like murmur. On CNS examination, there is no focal neurological deficit.
Okay. In a child with nephrotic syndrome, if liver and spleen are palpable, what are the probabilities? 1, 2, if one kidney or both the kidneys is or are palpable in a child with nephrotic syndrome, what is the significance? I have two questions for you. One, liver, spleen being palpable, other kidney or kidneys being palpable. Anybody can put in the chat box also.
Sir, if there is a severe edema, so organ is not able to palpate. But in case of mild edema, then organs can be palpable.
No. I'm saying there is nephrotic syndrome. But liver and spleen are palpable. What is your inference? Nephrotic syndrome, one kidney is palpable. What is your inference?
So we can think of other like complications is there or infections like malaria.
No. Actually, what you should think of is a push down because of massive anasarca pleural fluid. Bilateral pleural fluid, mind you, can push the diaphragm down and can cause visceroptosis and cause mild hepatosplenomegaly in very young infants with nephrotic syndrome 1. Second, in an older child, if you have true hepatosplenomegaly in a child with nephrotic syndrome, you will have to think of lymphoma, which can also cause nephrotic syndrome. One kidney being palpable, particularly if it is tender, you should make you think of renal vein thrombosis as a complication of nephrotic syndrome. These are the exam viva questions that we ask if you are given a very simple, what looks like a simple case of nephrotic syndrome. Okay, go ahead. On a similar note, suppose while palpating a child's abdomen, you find tenderness all over. What does it mean to you in nephrotic syndrome?
We can think of complications like
Complication.
spontaneous bacterial peritonitis.
Which
So,
organism? Which organism? Which organism causes? Can anybody put in the
sir,
chat box?
Streptococcus pneumococci, pneumonia,
Bacterial peritonitis is
Streptococcus pneumonia.
Yes, pneumococcal disease. Okay, go ahead. Go ahead.
Investigation.
No. What happened? What is your system examination? What about other systems? Everything is normal. Okay.
Yes.
Now summary of the entire case and diagnosis. Dr. Kosam, you can ask some questions. Sir?
Yeah.
Yeah, you can ask some questions, sir. You can add to it.
Yeah, I think he can proceed further.
Okay, right. Proceed. So what's your complete diagnosis at the end of history and physical examination?
So this is the first episode of idiopathic nephrotic syndrome. Most likely minimal change disease.
Okay, right. So what do you do for this child?
So urine analysis we can do.
First thing, if the child comes to your OPD, will you treat this as OP or IP? This given child, present status, present findings. If you are the postgraduate who's running the OPD, the answer should be first episode. It is always better to hospitalize. Use the opportunity to complete the investigations and counsel the family and then start treatment. That should be your answer. Preferable, though it is not mandatory. Okay? But in this child who has got such a severe anasarca, I would definitely hospitalize the child and treat the child. Evaluate and treat the child. Okay? Go ahead. Re-investigate. Why not this be acute glomerulonephritis? That's my standard exam question. Before you go to the investigation, Dr. Umesh, why not this child be having acute glomerulonephritis and not nephrotic syndrome?
So in acute glomerulonephritis, the child may be present with hematuria or hypertension, mild edema. The age group may be school-going age group. So
anything else?
BP,
Yeah. Anything else? History of streptococcal sore throat or impetigo may be there. preceding the renal illness. Okay,
Yes,
right? Anything else? Anything else? If a child has got cardiac failure, it is more likely to be nephritis rather than nephrotic syndrome. Respiratory distress, hypertensive cardiac failure, hypertensive encephalopathy. Okay, you only said severe headache, altered sensorium. All those are features of nephritis rather than nephrotic syndrome. Nephrotic syndrome, right?
yes,
Healed
sir.
lesions, say impetigo and scabies may give a clue it is nephritis. Nephritis, right?
Yes,
Gross hematuria is a feature of glomerulonephritis.
nephritis.
On the other hand, in nephrotic syndrome, the urine is likely to be frothy because of proteinuria, but colorless. Frothy, colorless. Okay, right. Go ahead.
So on urine analysis, urine routine microscopy, urine protein found to be grade 3, sugar is nil, WBC is 8 to 10 per high power field, RBC is 1 to high power field.
What is the significance of protein 1 plus, 2 plus, 3 plus, 4 plus?
So, so, so grading depends on particular concentration of protein excrete.
How much is 1 plus? How much is 2 plus? How much is 3 plus?
So if it is negative, then it may be less than 10 milligram. And if it is stress, then 10 to 20 milligram. Plus 130, 30 milligram. Plus 200 milligram. Plus 4, 300. And plus 4 more than 1000, 1 gram per DL.
Okay. What's the usual amount of protein in nephrotic syndrome?
सर सर डिफाइन करने के लिए वो मोर देन 1 ग्राम पर मीटर स्क्वायर पर डे और
Okay.
मोर देन 40
40 milligram per
पर
meter square.
मीटर स्क्वायर पर आवर.
Okay. Okay. Right. Right. Okay. Go ahead. Go ahead. Go ahead.
On blood investigation, total protein found to be 3.6 gram per DL, serum albumin 1.5 gram per DL, total cholesterol is 469 milligram per DL, triglyceride 55 milligram per DL, hemoglobin is 9.1 gram per DL, TLC is 11,000, platelet is 5.6 lakh per mmq.
Why there is thrombocytosis in the patient? Can you explain?
Sir, yes sir.
Thrombocytosis is there, no?
Maybe so. If with hemo concentration,
Hemo concentration will not cause thrombocytosis.
sir, intravascular volume.
9.1, HB is 9.1. What is the possible cause of thrombocytosis in this patient?
So decrease intravascular volume.
That will not cause thrombocytosis.
Check MCV.
Most likely iron deficiency. Okay. Reactive thrombocytosis because of iron deficiency.
Okay.
Next.
See, two things. 1 minute. Please go to the previous. See, two things. It's very unusual for, please go to the next slide. It's extremely unusual for a child with nephrotic syndrome to have a hemoglobin of 9.1. Even if there is no hemo concentration, hemoglobin is lower in this child. I don't know whether there is an underlying iron deficiency in this child. One. Second is, you must remember in children with nephrotic syndrome, if they have severe anasarca, if there is increase in the PCV, you should always be very, very careful about giving diuretics for these children because it can precipitate thrombosis. So you should be extremely careful in these children if the hemoglobin is higher than normal. If the PCV is high, in fact, you know that the basic hemoglobin in this child is low and it has gone up now, it would indicate that there is the intravascular volume depletion. And if you give furosemide for these children, if there is anasarca, you can end up giving the baby a stroke. Okay?
Yes.
Right. Go ahead, Doctor.
So, serum electrolytes and RFT are also done. Sodium is 127 milliequivalent per liter. Potassium is 5 milliequivalent per liter. Calcium is 7.2 milligram per DL. Urea
Is that not low? Is
Hello?
that not?
Sir.
How do you explain the low calcium?
So there's a hypoalbuminemia. So
Yeah, correct. Calcium must always be interpreted
binding
along with albumin levels. Yeah, go ahead.
So provisionally, this is the first provisional diagnosis. This is the first episode idiopathic nephrotic syndrome. Most likely is a minimal change in nephrotic syndrome without any complications.
Okay. Agreed. What do you do for this child?
So we can start treatment on steroids.
Okay. Before that, I'm going to ask you a very peculiar question. This can, of course, nowadays in DNB, they don't keep counseling stations, but we used to keep, and this is one of the commonest stations we used to keep. A child is diagnosed for the first time nephrotic syndrome. You are about to start treatment. Counsel the family. Can you tell me what are all the points that you will tell the family before starting therapy? How will you counsel them? How will you make lay parents who understand the disease, the treatment, the implications of treatment, etc.? Dr. Umesh. Yes, please.
Sir,
Yeah.
can we counsel the parents about the about the treatment कि कैसे मतलब क्या करना है?
Before treatment, how will you make them understand the pathogenesis and the pathology of the disease and the nature of the disease? Because the moment you say nephrotic syndrome, renal problem, kidney failure, all that fears will be there in the family. How will you convince them?
Sir, means to say, how will you explain to them what is the disease?
Yes, counseling. Yes, Umesh. Okay, I'll make it easier for you. The best way to explain to the family, before you start talking about the disease in detail, the first thing you do is to reassure them that your child does not have renal failure. But that is what everybody, the moment you say kidney problem, they will all be very much worried. So the first thing you tell them is that this is not renal failure. Please don't think that your child is going to need treatment like some adults in the family undergoing dialysis. That's the first statement you should make. Second, in simple layman's terms, you should explain the pathogenesis of the disease. How? You should tell them that the kidneys are functioning nearly normally in your child, but there is one function which the kidney should normally perform well. Your child's kidneys are now not carrying out that function well. What function? It is a filter. That is, normally proteins are not allowed to be leaked outside the blood into the urine. Your child's kidneys, which are functioning fairly normally, have lost the ability temporarily in holding on to the protein which is going to the renal parenchyma, and it is leaking out protein. Rest of the functions are being carried out well by your child's kidneys. That's how you reassure them. The third point you tell them is about how and why they develop edema. They develop edema mainly because of lack of protein and so many other factors, right? The fourth point you must talk to them is about the proneness for infection. So you should advise them to avoid overcrowding, etc., etc. And the fifth thing, you should reassure them. You should reassure them that by and large, nephrotic syndrome in a 2.5-year-old child, the outcome, long term and short term, both are extremely good. Next point you are going to talk about is therapy. You should tell them about steroids, risk of immunosuppression, need to avoid people with infection coming home, etc., avoid overcrowding, etc. And ultimately give them a very optimistic prognosis. And also mention about steroid side effects can happen. Okay, that is a way to go about counseling parents with nephrotic syndrome, right? And
Yes, sir.
last but not the least, the parents will ask, will you cure my child's illness with steroids? You should be very honest in saying majority of children respond very well, and also nearly 40 to 70% may have relapse once, twice, or even 3 times. But by and large, most children with nephrotic syndrome at 2.5 years go into permanent remission, though we cannot predict when this will happen. Even if there are relapses, we have efficient means of treating, and this child is not likely to go in for renal failure or for dialysis in future. That is a way to counsel regarding nephrotic syndrome. Of course, somebody has put in the chat box TB, steroids, etc., all those things. Okay, that's the way to counsel. Yes, Dr. Kosam, you want to add anything? Sir?
I think before starting steroid, would you want to do anything else?
Yes, sir. So, Montauk test or can be done to rule out tuberculosis, because steroid also further causes immunosuppression and will worsening the tuberculosis.
Not only tuberculosis, you should also rule out presence of any hidden focus of infection, which you might have missed. So you should also rule out infection. Then you start on the corticosteroid regimen.
Okay. Yes.
Incidentally, tuberculosis Manto test is now been given up by the National Tuberculosis Eradication Program. For postgraduates who are listening, CYTB test is going to replace Manto test. CYTB test, manufactured by the Serum Institute of India, is going to replace tuberculin test for diagnosis of latent tuberculosis. It's a skin test which is far superior with less false positives than Manto. Manto is no more recommended by the National Tuberculosis Eradication Program. If parents can afford, you can do gamma interferon until CYTB test is available. Okay?
Yes.
Thank you. Go ahead. How do you treat this child? How are you going to treat this child?
So starting Hello.
Yes.
Yeah.
So dietary modification.
What dietary modification?
Salt restriction should be done.
Salt restriction. When do you advise salt restriction in nephrotic syndrome? To everybody?
Severe edema present.
Yeah, only when there is severe anasarca. In this child, probably from what you say, it looks like having severe anasarca. The respiratory distress is there, severe anasarca is there. Then perhaps you can advise salt restriction. But run-of-the-mill garden variety nephrotic syndromes don't require any salt restriction. You can give normal diet, high protein diet. Okay? Right.
Why do
Go
you
ahead.
want to restrict salt? Why do you want to restrict salt in anasarca? Here the cause of edema is hypoproteinemia, no? So how will salt restriction help?
Sir, if there is a salt is also the sodium present in the extra, there is a pooling of sodium from intravascular to extravascular, and so it is difficult to subside edema if more salt is there.
That is not the reason, no?
If there is no severe anasarca, there is no need for salt restriction. That is what Dr. Kosam is trying to
But
tell
why
you.
do you do salt restriction? The reason behind it, I wanted to know.
So more sodium, more water retention, it will worsening the edema.
Basically, there is apart from the hypoproteinemia causing fluid loss into the interstitial compartment, there is also activation of the renin-angiotensin system secondary to intravascular volume depletion. That causes salt, the salt and water retention.
Yes.
When you give steroids, it further causes salt retention. So that may increase edema initially. That's why you want to do salt restriction in severe edema. Understood?
Oh, yes, sir.
Yeah. And what will we do for edema itself? For edema itself, what will you do? You want to give any treatment for the edema which the child is having?
Sir, if there is if it is affecting if severe edema, if it causes respiratory distress, then we can give Lasix.
What is the protocol? Suppose that you are saying the child is having anasarca, no? Generalized edema is there. So what is the protocol for management of generalized edema in a patient of nephrotic syndrome?
So first we check is there any sign of hypovolemia?
So is the patient having signs of hypovolemia or not?
No, sir.
How do you know that?
So there's no tachycardia, no respiratory distress, no
So not
pressure,
necessarily
no hypertension.
no hypotension. Any other thing?
CRT is normal.
CRT is a sign of shock. No, we are talking about hypovolemia. Normovolemic, hypervolemic, or hypovolemic. So hypovolemic, is this patient hypovolemic or not?
Yes, yes, sir.
How do you know that? Because the patient can be edematous and still can be hypovolemic.
Sir, if it hypovolemia, then
Measurement of hematocrit, that's what will give a clue to the presence of dehydration,
definitely.
hypo. Yeah, okay, right? That's what will give you the clue.
So suppose the patient is hypervolemic. Okay, so what will you do? Yeah, normovolemic with edema. What will you do? Next step. And
You
there is
said you will
severe
give diuretic. Will you give diuretic alone or with something else? That's what
albumin के साथ.
Yeah, always you must remember you should give albumin 1 gram
followed by diuretics.
followed by furosemide. If there is respiratory distress, massive ascites interfering with the respiration, penile edema interfering with or vulvar edema interfering with maturation. Okay, if these are there, then you should give albumin with furosemide. In fact, some books even mention metalozone can be given instead of furosemide, but you should never give these diuretics without albumin simultaneously, right? Because it can end up in a stroke. Okay, my next question to you, how does nephrotic syndrome predispose to infection? What is the pathogenesis of proneness of infection in nephrotic syndrome?
So, there's a urinary protein loss, so immunoglobulins loss hoga, or so that will
Which
include
immunoglobulin is lost in the urine?
IgG.
Ig, low molecular weight protein, IgG. Very good. One. Yeah. Two.
So, low complement level.
Excellent. Complement is also lost in the urine. 2, 3. Others can put in the chat box. Okay, I'll complete it. 3. Opsonins are lost in the urine. 4. Edema itself is a good culture medium for infection. 5. Because of decreased blood volume due to edema, splenic function is affected. There is relative functional hyposplenism because of decreased blood volume due to edema, right? IgG production itself is decreased. Okay.
Yes, sir.
These steroid therapy increases the risk of infection. So many points are there when it comes to infection in nephrotic syndrome. And they are prone for infections due to capsulated organisms and organisms which require complement for destruction. Okay? The
Yes,
most
sir.
notorious infection being pneumococcal peritonitis. Right? Please
Yes.
go ahead. Yeah. Yes, Dr. Kosam. So what treatment is the protocol that you will adopt for this child? What is the treatment protocol you are going to follow?
So, steroid में prednisolone for daily dose 2 milligram per kg per day for 6 weeks,
You
followed
go
by
by gram per kg or body surface area? Preferable to have a body surface area. 60 milligram per square meter body
meters.
surface area is the initial. Okay. How
Yes,
long you give and
for
when do you
6
expect
weeks.
response? In this
So,
child, start steroids. After evaluation, you have done the workup. When do you expect the response to occur? Yes, please. Standard examination.
after 2 weeks, or
No, not after 1 to 2 weeks. Majority will start remitting in 1 to 2 weeks. Majority, 90%. 90%. Okay.
yes,
Then if they remit, what do you do?
then after 6 weeks, followed by 1.2,
Yeah.
1.5 milligram per
Yeah.
kg per day,
Are
or
you going to give daily steroids OD or in 2 divided doses?
sir, can be given OD or BD, but OD
Preferable to
OD
more response is likely if you give divided doses. 6 weeks, then what do you do?
alternative therapy,
What's the dose?
1.5 milligram per kg per day,
40
or 40
milligram.
milligram per meter square.
Then originally it was for another 6 weeks. Now they have extended. Even after 6 weeks, you slowly taper and stop the therapy. Okay? Right.
Yes.
Will you do C3 in nephrotic syndrome? And if you do it, when will you do it? And how do you interpret C3 levels in nephrotic syndrome?
Yes. So we can do C3 levels to rule out the nephritic causes.
Should you do it routinely in all cases?
No, sir. If there is hematuria or persistent
If you
hypertension,
suspect
then
nephritis, suspect nephritis, particularly when nephrotic syndrome is associated with hematuria, severe hypertension, or nephrotic syndrome occurs in an older child. Okay, when you
Yes.
suspect nephrotic syndrome, always do a C3.
C3 levels.
And if your C3 is low, you should always be careful about starting steroids. Right? It's not routinely recommended. Not routinely recommended. Okay? Right.
Yes.
Yes, Dr. Kosam, you want to ask some questions? Sir?
Okay, after having given 6 weeks of steroid, what is the upper limit for the response in a steroid-sensitive nephrotic syndrome?
So till 4 weeks,
4 weeks, or it
4 to
is it
6 weeks,
6
not responding, then it can be nephrotic steroid resistant nephrotic syndrome.
It is 6 weeks. No, most of the patient will respond in 4 weeks. But if the patient does not respond in 4 weeks, you should continue it for 6 weeks to label it as
Nephrotic was steroid resistant nephrotic syndrome.
Late
steroid
response
resistant.
can occur even between 4 to 6 weeks.
Suppose you have labeled the patient as steroid resistant nephrotic syndrome and the patient did not go into remission after 6 weeks. So what will you do next?
So we can add calcineurin inhibitors.
You will directly add calcineurin inhibitors?
So we can continue low dose steroids along with tacrolimus or cyclosporin.
Okay, basically, if you are labeling a patient, this is a primary steroid resistance, means that is the first time the patient is receiving the steroid and the first time it has come out to be steroid resistant. So it is a primary steroid resistance. So first of all, you have to subject the patient to renal biopsy. And this is another indication, a primary steroid resistance is indication to the genetic test. Okay.
Okay, sir.
And then you don't directly go for calcineurin inhibitors. Directly, you don't switch to calcineurin inhibitors. First, you go for second line drugs.
Okay, sir.
Which second line drug will you start?
So levamisole, mycophenolate mofetil.
Okay, levamisole, MMF. Okay, good. And what about steroids?
So steroids would be continued low dose, 0.5 to 0.7 milligram per kg.
Okay. Then how much time will you wait?
So for 9 to 12 months.
Need to see for the response. You have started on second line drug. You want to see the response. How much time will you wait for the response of second line drug?
So 6 month के बाद reassess करेंगे.
6 months for response. Remission, that means I'm talking about remission. You can't wait for 6 months, no? The patient should respond within 2 to 3 weeks. If there is no response, then that is known as what? Nephrotic syndrome. Then you will go for calcineurin inhibitors, tacrolimus or the second line drug, third line drug. Okay.
Yes, sir.
Dr. Umesh, what is the meaning of the term remission? When do you use the term remission?
So urine protein is nil or trace for 3 consecutive days.
Very good. Or if you, there's some other, can you do any test other than urine protein?
Spot PCR, urine PCR.
Yeah, protein creatinine ratio of less than 0.2.
0.2 for 3 consecutive days.
On a similar note, child with nephrotic syndrome, you are treating, it has gone into remission. How do you detect relapse? How do you, as a general pediatrician, as a primary pediatrician, how do you detect relapse? Do you think parents themselves can detect relapse at home?
Sir, urine protein grade 3, grade 4,
Excellent. Again,
or
on a similar note,
3 consecutive days.
3 consecutive early morning sessions, if the urine protein is 3 more than 3 plus, or urine protein grade ratio more than 2
Then
milligram 2, then it is again relapse. Okay.
Yes, sir.
What is the definition of partial remission?
So,
Is there any term called partial remission?
sir,
A few children with nephrotic syndrome may not have edema, but they may continue to have urine protein 1 plus or 2 plus,
2 plus.
or protein grade ratio of 0.2 to 2, and urine protein also slightly being higher. That is called partial remission. It's called partial remission. Okay. The other definitions already Sir Kosam sir mentioned: steroid dependence and steroid resistance. He already said 6 weeks. If there is no response, it is steroid resistance. What do you mean by steroid dependence?
Sir, relapse appearance of symptoms, urine protein creatinine ratio, grade 3
Within 14 days of
after
discontinuation of
stopping steroid
steroids,
or tapering on alternative.
the relapse occurs 2 consecutive relapses while being on alternate day steroid. That's the definition of steroid dependence. That is, child is on alternate day steroids, and within 14 days of discontinuation, you get 2 consecutive relapses. That is steroid dependence. Okay. And finally, last question is, what is the age limit for congenital nephrotic syndrome?
Sir, 1 year, 3 congenital 1
Any
year.
nephrotic syndrome with an onset of less than 3 months should be considered as congenital nephrotic syndrome. Any nephrotic syndrome having onset below 3 months. Okay, right. Dr. Kosam and Dr. Motwani, you want to add anything?
Yeah, so you just mentioned about congenital nephrotic syndrome. So if you get a patient of that, so what test would you want to do? One test, tell me, which you want to do in a patient of congenital nephrotic syndrome. And that test is very important.
So torch profile or sir, genetic testing.
Okay, oh, that is one of the cause, but you want to do a genetic test. Why do you want to do genetic test? What is the importance of genetic testing in a patient of congenital nephrotic syndrome?
So to identify the type of gene affected or mutations.
So how that will help? Suppose you have done a genetic test and you have found some gene mutation.
So sir.
Yes, sir. Anything else? Dr. Motwani, you want to ask anything?
No, sir. I think this time is also up. Kosam sir is asking few questions. After that, we'll wind up, sir.
Okay. Dr. Kosam, sir, you can continue.
Yeah, I think
Sir?
we are done. Yeah, I think we are done.
Yeah.
Okay. Of course, the final question I want to ask, standard exam question. When do you do renal biopsy in nephrotic syndrome, and when do you straight away send the child to a nephrologist for a renal biopsy?
If there is a persistent microscopic hematuria, gross hematuria,
Excellent.
or steroid-resistant nephrotic syndrome, and low complement level,
which is persistent or
persistent
excellent, low C3 level, excellent.
And
if you clinically suspect secondary nephrotic, for example, you have a child with fever, rash, something suggesting vasculitis, I don't think you will start steroids without a renal biopsy.
Yes, sir.
Again, if a child with nephrotic syndrome has got acute kidney injury, you have corrected the hypovolemia, in spite of that the child has high urea creatinine, you should do a biopsy. And corticosteroid resistance, either it is initial or late, you should consider biopsy. Last but not the least, whenever you want to start calcineurin inhibitors, you should do a biopsy. Sir, you want to add anything, Dr. Kosam? This is one standard question we used to ask in the exam.
Yeah.
Any other comments? We can wind up.
Yeah, so I think we
Students
can wind up.
can put in the chat box any doubts. Okay, well done, Umesh. Right? You presented very well. You discussed very well. Okay. Excellent. All the best to you. My blessings to you. Thank you, Dr. Kosam. Over to Naresh.
Yeah, I think it is heartening to see so many PGs and also other colleagues and pediatricians joining this. And I think Dr. Umesh has done fairly well. I think he'll go with a lot of confidence from here. He did a real good presentation. Only thing he was lacking in little confidence, but I'm sure he'll get better and better from here. Over to Dr. Sandeep Thute.
Thank you, sir. On behalf of Durg Bhilai Academy of Pediatrics, we thank our experts, Dr. Subramanian sir and Dr. Ajay Kosam sir, for today's PG clinics. It is always a wonderful learning experience for PGs as well as all the academicians of our state. And I would like to thank Dr. Umesh Vishwakarma for his wonderful presentation. Thanks all esteemed members and dear postgraduate students for attending in good numbers and making it a successful one. At last, I would like to thank Team Zuventus for providing this digital platform. So with this, we end today's session. Thanks once again and good night all of you. Thank you. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, Bala sir, Kosam sir. Good night all. Thank you.
Good night.
Thank you, sir.
Thanks.